All right, so we're at class 15, October 13th. We're getting far into the semester here. So we want to continue our discussion of healthcare, health insurance, healthcare reform. We started this collection of articles last time. We didn't get very far. And the articles are organized somewhat by topic, although there are some articles that hit several topics, so it's hard to put them into a group, perfectly into a group. But I give you the title of each article and then a few pages of highlighted notes. So I'm only going to focus in on the highlights. You can certainly read more than the highlights. And then I'm going to tie each one of these articles back to the rubric. So again, make sure you're ready to, you have the Word document open and then be ready to hit pause on the video. So if you see a really great quote you want to bring into your organization, your outline of the paper, you can do that. So this first one, you might wonder, why do I have this article here? So it's the National Health Service, which is Britain. So the key here is to understand that healthcare, while it's a special problem in the U.S., it's a problem everywhere in the world. So you're not supposed to talk badly about the NHS in Britain, but its problems are becoming pretty serious. They've had some austerity. Obviously, COVID-19 has changed that. Boris Johnson's been talking a little differently than his predecessor. So you have more baby boomers in UK, just like you have in the US. Hospitals are struggling. They're having a tough time seeing people in a reasonable amount of time. So the size of the problem is an issue for more than just the U.S. But the U.S. is much more impacted, seriously negatively impacted. This is a great chart that you might want to bring into your paper. This is on page 6. It's the next article. But it's a great article to bring up this graph at the very beginning of your paper if you want to show. Now, it's a little dated. That's the part of the problem. It only goes through 2014. If you want to try to find one that's more current, I'm always looking, always on the lookout. There might be a few articles later. I think there's one in particular. I don't mind you using out-of-date articles on this. This article is specifically asking about the Affordable Care Act and whether or not it's working. We still don't have the answer to that question. President Trump made some pretty significant changes to it. Whether or not it's working, we'll find out this November again how much the premiums will be going up on healthcare.gov, but the size of the problem in the U.S. much higher. And if you look back in the 70s, this is what I was talking about. Everybody was seeing their healthcare rise. The U.S. was high as everybody else, but the issue is the U.S. inflation for healthcare just kept rising just at the same rate it had been in the 70s, even though we were past all that in the 70s. So yeah, it's very unique in the United States. A continuous article, America's health system is terrible at controlling costs. Why insurers and Medicare pay doctors when they deliver the service rather than when they keep the patients well. So this gets back to this idea of a focus on treatment over prevention. We're focused on treating people because that's what the system, that very first article we talked about. They want volume. This is their business and they can create their own demand. So they're not focused on keeping us well or our quality of life. They're focused on treating us. Second, America relies on private doctors and insurers, but their costs and quality remain opaque. That's going to be a big issue we're going to talk about with the solutions is, can we take this very inelastic demand for health insurance, healthcare, that people are willing to pay almost anything because they're not directly paying for it? There's a way to shift that so people start pricing on both cost and quality like we do for every other product. But the healthcare system itself has fought to hide performance and prices. So patients are in the dark, and when they visit the doctor, they have no idea what anything costs. What other business can you say that about? They do not, they have not objected when doctors gave unnecessary tests or overcharged. An example here is a prostate-specific antigen test could cost $20 in Philadelphia and $407 somewhere else in Philadelphia. The quality is erratic. They found rates of complications for cesarean deliveries varied nearly 5-fold among American hospitals. Wouldn't you want to have that information? So the complexity of the system and complexity of lack of price transparency and an inconsistency of cost and quality city to city. This article covers several things in just a few paragraphs. And here's the chart they were referencing. So you can just show the inconsistency between cities. In New York, mammograms, they range from a few dollars to over almost $1,700. PSA tests, a very, very simple test, and it can cost a few $100s. I don't know why it would cost a few $100s or who would pay for that. But it varies, but notice how different every city is. Now, when we may talk somewhat why Cincinnati is so low, there is a good reason for that because of what it's located in Cincinnati. But boy, you can see pretty wide ranges throughout. Page 9 of the article, United Health, Aetna, Humana, Kaiser Permanente. We'll hear more about Kaiser in later articles. Those are insurance and health companies have given reams of data to the Independent Research Center. Next year it will be launch a website where any insured patient can log in and view quality and cost information. Now, I don't know if that's been set up. Some of you may want to do your own little research and see if that's there. But that's part of the solution. Let's provide information on quality so consumers actually start looking up quality and price. They don't, we'll talk about price separately, but patients to say how much does it cost and what are your quality records. If we could get that, boy, you would see a collapse in that dispersion of prices. And hospitals with low quality scores would fix their problems. They would have no trouble, no choice. And so we want patients to see the full cost and actually make informed decisions. We want to unlock consumerism. We want to, so this is one of the solutions. You can hear I say we, but I'm saying there are a large number that say we've got to get the consumer back into this. We have to get patients acting in healthcare like they do when they buy anything else. Here's the next article, England's National Health System. So again, we're talking about the NHS. So more fundamentally, the focus must shift away from treating illness and towards preventing it. So even in Britain, there's an emphasis on treatment over making people well. Today, 70% of the spending is on long-term illnesses. So we'll have to talk about long-term illnesses, chronic illnesses, and what does that mean? And can we get people to change their lifestyle, reduce obesity? Is it better to reduce obesity versus giving people pills to treat diabetes? Isn't that better? We're going to talk more about that in some later articles. And that's one area I think you could really put some thought into. The NHS providers are paid for the procedures they carry out, not for those that they render unnecessary by making people thinner and healthier. A better model will be to give, and here we get into a solution, give health providers a budget based on their population they serve and pay them according to their ability to meet targets related to our healthiness, to public health. This would increase the incentives to use new technology that would give patients more responsibility for their own health. You're seeing that with Apple applications of people counting steps and those type of things. This will come back. We're going to very much see this article, this issue brought up with Michael Porter. And that's supposed what he calls outcomes-based medicine. It's real exciting, but can it actually work? Then page 13, another NHS article. As more people enter and live longer in adult age, demand increases for two costly types of care. First is looking after the dying. About 25% of all hospital inpatient spending during a person's lifetime occurs in the last 3 months. And I know many examples of that. My grandfather, incredibly healthy his entire life, and then he fell doing something he probably shouldn't have been doing, climbing a tree on a ladder as an 80-something-year-old man, very heavy, very overweight. They called him Tiny, but he was a huge guy. So it was somewhat of an ironic nickname. After that fall, his health deteriorated, and boy, he spent a lot of money in hospitals the last few months of his life. So it's very, very true. And then 70% of NHS spending goes on long-term illnesses. So that's paying for the baby boomers. It's an issue. It's an issue that you're going to have to address, and there's some really tough ones. You see the next one down there, end-of-life care. Both of those go with this article. It's just a tough thing to deal with. Most hospitals still don't know what they buy, how much they buy, and what they pay for goods and services. There's a huge variation in costs and outcomes. hip replacements, hospitals, and this is NHS again. So I'm trying to show you that this is not just a US problem. You can see ranges from 800 pounds to 1,600 pounds. Rates for deep wound infection and avoidable complication. So, these are deep wound infections. These are things that hospital cause their patients because they didn't follow good protocol. They can vary from 0.5% to 4%. So some hospitals have very high quality standards, some have very low quality standards. Reducing the average to 1% would improve the lives of 6,000 patients per year and save $300 million. The NHS tariff system rewards repeat activity rather than innovation. We've seen that before. They wanted to use Skype to show patients remotely how to remove their children's dressings. Yet he was prevented from doing so because the tariff price for telemedicine consultation was too low. Patients instead came into the hospital for more expensive treatment. There are too many hospitals across the world. Chains are scaling up. Specialized care is better at scale. Surgery is about practice and volume. We're definitely going to get into that when we talk about Michael Porter. There are certain things where you want someone to have been doing thousands of them. And you only want, even if we have to fly people across the country to these specialized hospitals that do these surgeries over and over and over again, their costs will be lower and their quality will be higher. So Michael Porter will definitely talk about that. So there's a lot of things here. Complexity of the system, lack of price transparency, the inconsistency of quality between cities and cost between cities, and inefficiencies actually encouraged. You see this is Skype example. It just encouraged people to do more expensive thing, and then we'll get into the Michael Porter at the end about these specialized care units. So page 18, the future of NHS lies in accountable care organizations. The Affordable Care Act had something very similar. These are ways to try to reward entities that actually cut costs in healthcare. I'm not sure if these organizations have really done much in the US. We'll see a few articles where there was some excitement early on, but it seems to have petered out, so not so sure. There are increasingly popular ways for organizing healthcare in countries like America, Germany, Singapore. In each case, a single provider is responsible for all healthcare in its area. It is paid for outcomes, not activities. It is given a budget adjusted for the health of the population. So what some people say is, hey, I live in Florida. There's a lot of old people in Florida. I shouldn't have the same budget as someone that's in Phoenix, Arizona, or wherever there's young people, San Diego. So as long as it meets its targets, it gets paid. So you move from volume to value, and this whole thing is Michael Porter. We're going to see all of this. Michael Porter is going to get into it in much more detail. So you might, if you see some quotes there you want to bring in, that's good, but then realize you're probably going to be writing most of this from the Michael Porter article. All right, let's move on to page 19. Again, another Affordable Care Act article. So what's going on? This is a few years old again. America's hospitals are the most expensive part of the world's most expensive healthcare system. So there's some background on why it's so expensive in the U.S. Trying to drive patients out of its hospitals into cheaper clinics, that's a solution. I don't have it under solutions, but you'll see under solutions, we'll get into this, the alternative ways to give care besides hospitals. America has more than 5,700 hospitals, with nonprofits outnumbering for-profits by nearly 3 to 1. So some people say it's a problem with the profit incentive. We have hospitals trying to make money, so of course everything costs a lot. They got a profit incentive, and yet we have the majority of our hospitals are not-for-profit hospitals. Most of these share a facility, a familiar business models, sell as many services as possible at the highest price. Doctors receive a fee for each treatment, so there are few financial incentives to keep patients well. So it gets back to this focus on treatment over prevention. So here's a good example of just the size of the problem here. You want to talk specific about hospitals. This is a per day cost, $4,300. The most I've ever spent for a really nice hotel. I actually stayed in the nicest hotel in the United States, according to a survey. Really, really nice hotel. Chandeliers in the room, chandelier even in the bathroom. I had my own butler, which I'd never had a butler before. That was a $1,000 night hotel. In today's dollars, maybe it's $1,500, $1,600. But that was a really nice hotel, but doesn't compare anywhere to staying one night in a hospital. Why is it so expensive? That's the hospital stay. We're not talking about the doctor's time and the other charges. So very, very expensive. Employers have increasingly required their workers to make out-of-pocket contributions toward the cost of their health care. So again, let's put the consumer into this. Let's make patients act like consumers because they're paying more of it themselves, so they'll actually shop around. The Affordable Care Act also includes incentives for hospitals to provide quality rather than quantity. That's that affordable care organizations that we'll talk about. Groups of doctors and hospitals can apply to be designated for an accountable care organization, ACO, which will be rewarded for keeping the patients below certain levels. So again, we're trying to unlock consumerism, and we'll get back to this outcome-based medicine, which is a wonderful term. Outcome-based medicine. So we're focused not on how many people we treat and how many treatments we give. We're actually focused on how healthy is the population we're responsible for. The most seismic shift, however, is the move away from fee-for-service. How can a hospital profit from delivering fewer services when it is organized to deliver more? Reward it for keeping patients well. Ensure that patients do not suffer expensive relapses. Nurses scroll through records to confirm that patients have collected their prescriptions and had their checkups, more home visits. So you notice the focus here, and again, it all gets back to this Michael Porter idea. If you change your focus, including where you spend your money, how you hire people, what time you spend, you change your focus on where are the areas where we get the biggest bang for the buck, where we might treat people less, give them less services, because we figure out where's those crucial points. So we might find out that patients are not taking their medication. And so we actually pay nurses or other hospital staff to make sure the patients are taking their medication. You might even send someone to someone's house. You know, it's a particular group that's particularly vulnerable. I'm going through this with a relative who has pills that she's supposed to take, and because she's having some cognitive issues, she can't remember what day it is, and she gets so confused, and it's very frustrating for her. So my brother has had to set up a system to help her know exactly, and it's a system that will not let her take a pill, unless it's the right time and right day. So this is an issue, especially older people. They get forgetful. They have a tough time remembering, and you may have seen some of those pill boxes people carry around. So they had their 7 pills they're supposed to take every day at different times. So can the medical system do something to focus on those areas where a little extra cost can greatly reduce costs in the future? More costs today, pay me now or pay me later. However, hospitals look at that and say, well, if we do that now, we make much less money in the future unless you pay us for making our patients well. So it's a huge theory. Page 23, the nasty surprises that plague our healthcare system. This is a really interesting article. A lack of market competition has allowed hospitals to strive while patients get hit with exorbitant, unexpected, unfair bills. So here's one. We're talking about this complexity of the system and lack of price transparency. I think there's some shocking things in this article. This is a more recent article just from a couple of years ago. So here's a lady, Elizabeth, was struck with a bill for $17,850 because a physician asked her to provide a urine sample. She didn't know that the doctor's testing lab was out of her insurance network. Her insurer, Blue Cross Blue Shield of Texas, which would have paid an in-service lab $101 for the service, refused to cover the bill at all. Fearing for his daughter's credit rating, her father bargained the bill down to $5,000 and paid. Now, when did she find this out? She found this out after the doctor asked her for that test. What system does that? When do you go in to get your car fixed and they fix it and come back and say, it's going to cost you $80,000. We had to do some things and your insurance doesn't cover it. This just doesn't no one would do that. You ask, how much will this cost up front? And if for some reason, while they start working on the car, they discover something else, they call you and say, hey, we discovered you've got a fan belt out. Do you want us to replace that? That's $150. Healthcare, they don't do that. They just give you the treatment. They ask if you can do it. They don't tell you about costs. You don't talk about costs. She just assumed her insurance covered it. And then she discovered afterwards that it didn't. You'll find out this is a trick that the insurance industry that the healthcare industry is actually doing. Tens of thousands of families who receive surprise medical bills every year. 22% of patients receive bills they did not expect. McAllen, Texas, right here in Texas, maybe one of the worst in the country. It's infamous for being the highest cost county in the U.S. for Medicare. 89% of them received balance bills from doctors who didn't take their insurance, even though the hospitals they visited did. Can you believe that? You go to a hospital where your insurance covers it, and yet you're thrown doctors who aren't employees of that hospital. You have no idea. You just assume, well, if the hospital is covered by plan, obviously any treatment I get here is. And they say, no, our anesthesiologists, they're not employees, they're contract labor, and they're not under our plan. That is just insane. Peter Dreyer at the bottom there, who needed neck surgery, received a $117,000 surprise bill from an assistant surgeon he hadn't known about or met. The assistant surgeon's charge was almost 20 times the $6,000 fee charged by the primary surgeon. Can you imagine? So the complexity of the system, that's just shocking. It's destroying families that have insurance. They're paying for insurance, and then they discover, well, I'm not really covered. The hospital or physician may charge $3,000 for a surgeon, but the insurer will disallow a huge chunk of that and only pay $750. The real price is $750. The $3,000 charge is a fictional price. And so what they're sending their patients, that's why we saw in that previous chart, that they negotiated that price down. That's because they're intentionally, grossly overcharging. And so if you're out of network, you get those grossly inflated bills. When an out-of-network provider bills a patient, no discount is applied. The insurer then pays the same $750, leaving the patient for whatever the rest is. The out-of-network provider has no duty to accept the insurer's payment as full compensation and is free to bill the patient for the balance. The phony made-up price suddenly becomes very real. The AMA, the real crux, now we can see we're going to have pointing fingers here. The AMA's, the American Medical Association, says the real crux of the problem is that the health insurers are refusing to pay fair market rates. Yeah, right. Insurers in turn accuse doctors of price gouging and hospitals of being complicit. It is the hospital's responsibility to contend to ensure that all physicians treating patients in their facility are covered by the same insurance contracts as the hospitals. So for hospitals to say, the AMA to say, we do this fraudulent billing. We give people these surprise bills because we can't get enough money from the insurance companies. And so what we'll do is we won't tell our patients that they're going to get this $117,000 bill. We'll just let them assume they're covered, and that way we can charge them all this money, and boy, we'll make up for what the insurance. That's crazy. The system is absolutely insane. Other hospitals seem to go out of their way to create opportunities for surprise bills. Many hospitals have no in-network anesthesiologists on their staffs either. After having her thumb operating, Elaine Hightower was balance billed for $6,300. What anesthesiologists? Well, because their work is somewhat generic. Their work is the same wherever they go. There's no reason for them to be on staff at the hospital. They can jump between hospitals, and so they become contract labor, and lo and behold, you think you're covered and you're not covered. Just crazy stuff. So a lot here on the complexity of this system. To make matters even worse, these doctors gain by remaining independent. They can still collect in-network payments from insurers and then can extract additional dollars from their patients by balance billing. Refusing to join insurers' networks is a dominant strategy for independent physicians. It's absolutely crazy, crazy stuff. All right, next article, same cancer, worse results, and twice the cost in the U.S. Americans pay twice as much as Canada for health care, but they didn't get twice the benefit, according to a new study. Patients with advanced colorectal cancer who lived in some cases mere miles from each other. A total of about $12,345 was spent a month on the cancer patients in his study who lived in Western Washington, whereas the monthly spending in British Columbia was half that. American patients in Washington with advanced cancer survived 21.4 months versus 22.1. So Canada not only, they're comparable, but Canada was half the price with slightly better outcomes. Now here I say inconsistent costs. I really mean that for the U.S., but here this one might fit better in your introduction and just why does the U.S. cost so much more? But you know, you could talk about inconsistency of the U.S. versus the rest of the world. We think if Medicare, being the largest payer for medication, could negotiate drug prices, the cost could go down overall, even for what private insurance pays. Under current policy, the U.S. Health and Human Services Secretary is explicitly forbidden, can you believe that, from negotiating directly with drug makers on behalf of people in Medicare, the program's prescription plan, so Part D. Medicare accounted for 29% of spending at drugstores. President Trump has repeatedly criticized the policy, and most Americans want it changed. But why isn't that? We're going to see this later when we look at this book on healthcare. The healthcare system donates a tremendous amount of money to politicians. And so here you've got this regulatory framework that prevents just efficiency. Other factors that drive the high price of U.S. healthcare are a lack of price transparency. Patients don't know what they're paying for until they get the bill. Prices vary widely, sometimes even in the same zip code. If patients knew what things cost, they might shop around, especially if more of it's coming out of their pockets. Administrative costs of healthcare are high, sometimes accounting for 25% of U.S. hospital spending, more than twice what we see in Canada. So our system's just expensive. Even forget about the care itself. We have more people, and it might be because of the way insurance is, because we have insurance coming from your employer through the insurance industry, and it's very tax subsidized, so we overuse the system. It just encourages waste. This is in part because the American healthcare system is fractured, meaning a doctor's office spends a lot of time on administrative tasks like filling out paperwork and chasing insurance companies to get paid. Canadian hospitals get a lump sum budget that covers costs of care. So you're seeing some hints here to the Michael Porter solution going on other places, but a lot of complexity and inefficiency of the insurance model. The insurance model adds costs to the system. You have the insurance company's costs, which is just a burden on the whole system, especially for those low severity types of events where we should be paying them out of pocket. Putting the insurance industry in there, it's going to raise costs 25%. And then the insurance industry itself makes hospitals more expensive. They have to add all this administrative burden. The notion that evidence might be used to limit care remains heretical. About 1/3 of the spending is waste, but America has a unique distaste for evidence. This is an incredible article. You know, part of the solution is we start asking the question, which treatment is the most effective? And Medicare and insurance should only cover the treatment that's the most effective, especially when it's the cheapest. If someone wants something more than that, then the insurance company would cover whatever that most effective treatment is, and that's all, and then the patient would have to cover more. So we'll see some examples of this. Knee surgery is a good example, where studies have found that rehabilitation is just as effective as knee surgery, especially 5 years later. There's no difference, and yet knee surgery costs several times more. And yet the Affordable Care Act specifically says Medicare cannot use this kind of outcome-based, evidence-based medicine to decide when they treat. So you heard, that's when you bring up these things. You hear congressmen and congresswomen talking about death panels. You know, the argument is, hey, we should leave this between the doctor and the patient. It's a private affair. But if the doctor makes 3 times more money if he does surgery, and he makes nothing if he sends the patient to rehabilitation, no, you don't want this between the doctor and the patient, because the doctor has bad incentives. So we have overtreatment, overdiagnosis. We're going to see a lot of this. This is a big issue here: overtreatment, overdiagnosis. President Obama's stimulus and health law included more than $1 billion to research the outcome, kind of outcome-based medicine, evidence-based. So I'm using two terms here. Evidence-based medicine is when you use statistics to figure out what treatment is the most effective. And then you compare that to the cost, and you're trying to find the most cost-effective. Outcome-based medicine is what medical system has the highest quality as far as our health relative to the cost. But they are somewhat related, because outcome-based medicine should be very much supported by evidence-based medicine. The task force unleashed a torrent of fury in 2009 when it recommended against mammograms for women in their 40s. We're going to see why they recommended this in a later article. Last month, the task force advised against routine prostate, the PSA test for men. The panel explained that for every life that the test saved, the treatment inspired those tests would have caused one man to develop a serious blood clot, 2 to have heart attacks, and at least 30 to become impotent or incontinent. So what they're saying is the treatment is more disastrous than the cure. Yeah, 1 in 14 might have their life saved, but half of those are going to have their life really destroyed. They may not die immediately from the prostate cancer, but they may die because of the blood clot or the heart attack. So this is here. Politicians, they call this task force a death panel. So that $1 billion on research, the way I understand it, and I'm curious if this is still the case, but originally the $1 billion for research was left in the Affordable Care Act, but especially the Republican Party, but I'm sure it came from both because of the money being poured into the Congress from this industry. But so $1 billion on research, but the Republican Party added in an amendment that said that information that was obtained with the $1 billion of research could not be used by Medicare to decide what they would cover and what they wouldn't cover. So again, overtreatment and diagnosis. We're going to get more into this. So here's one. This is a really good article as well. Over-tested Americans when cancer isn't cancer at all. So what we call cancer maybe shouldn't be called cancer at all. Cancers are heterogeneous and can follow multiple paths, not all of which progress to metastasis and death. You can tell me I have prostate cancer and that we're just going to watch it. So you can't tell me that. Yeah. When someone says you have cancer, you say, well, cut it out. And we're going to see when we watch this one video that I'm going to have you watch. I'll let you watch it in lieu of the class. I'll get that to you. It's an interesting video, and in particular, you're hearing people say, hey, if I got cancer, I want you to treat me. And what you're going to see in that video is the people who get that treatment for prostate cancer, about 1 out of 14 of them need it. One of those 14, the surgery will actually save their life. The other 13 do not need the treatment. They would live a normal life. They would die from something other than prostate cancer. So 13 of the 14 don't need the surgery. And so sometimes the best thing to do, and you'll see this in the video, is why don't we just monitor it? So new technology is increasingly able to find these abnormalities. So what we're calling cancer now might really not be cancer. We're finding stuff today that we would not have found 50 years ago. When we do so, our inclination is to act, even when the remedy turns out to be far more harmful than the disease would have been and had just run its course. Americans tend to be over-tested. This is a great quote. You might move this quote to this part of the paper. It's part of this over-treatment, over-diagnosis. It's going to be probably a big part of your paper. We tend to be over-treated, over-diagnosed, over-tested, over-diagnosed, over-treated across a variety of conditions. So this article says 10 to 30% of healthcare spending is that kind of waste, where we're treating people where we're actually making them worse off rather than better off. Now, when we're going to see something on Medicare, you can see some quotes of 30% to even over 50% is waste and fraud. So there's some people who actually have data that show that they can show that Medicare, over 50% of Medicare spending is waste and fraud. So it has a huge impact. So you're asking, why is the U.S. twice as expensive as other countries? Well, here's a big chunk of it right here, is we're giving a lot of treatments that are not improving people's health. Salaried physicians who received no income for increased volume and who had limited liability concerns still ordered more tests. So they weren't worried about malpractice. They weren't getting paid for treatment. So, salaried doctors is one of the solutions. This article seems to question that, but we'll see some others that maybe don't question it as much. An exaggerated perception of benefits of the tests. So we always feel good, right? I've been in that position several times. Well, let's run some tests just to be sure. You're saying, are you running tests to be sure, or are you running tests so that you can bill me more? Do I really need the test? Is it really going to tell you something? Some patients who are diagnosed with cancer do not need to be treated because that cancer is never going to bother them. The problem is that we don't know who those people are. And we'll get into this much more in the video. I think you're really going to like the video. Doctors know that approximately 10% of localized lung cancer tumors and 20 to 30% of localized breast cancer tumors that are found through screening would never cause harm. That tumor would just stay there, never grow, never spread. The rate is even higher with prostate cancer at 60%. So another one here's on breast cancer overdiagnosis. Overdiagnosis is a term many are unfamiliar with. In cancer medicine, it refers to a tumor that fulfills all laboratory criteria to be called cancer, but if left alone would cause no harm. So the problem is we don't know which is which. Although I will say, and you'll see this in some articles, where certain cancers like prostate cancer, if it is the cancer that's going to kill you, more than likely it's going to kill you anyway because it's so advanced, it's so far along, it's so aggressive. And if it's one that's not going to kill you, you're better off not getting the treatment. So, I mean, there are people whose lives are saved by the surgery, but there's a lot of people that, you know, even though you catch it, you don't catch it early enough and they still are going to die by the cancer. So the problem is related to advances in technology, as we just saw. Here's another overdiagnosis. That previous one was specific to breast cancer, so if you want more data on that, you have to read the entire article. But here's another one, overdiagnosis and overtreatment in cancer. National data demonstrates significant increases in early stage disease without a proportional decline in later stage disease. So think about that. Screening for breast cancer and prostate cancer appear to detect more cancers that are potentially clinically insignificant. In contrast, colon cancer and cervical cancer are examples of effective screening programs in which early detection and removal have reduced incidence as well as late-stage disease. So think about that. We have cancers like breast cancer and prostate cancer where we're screening and finding a lot more cancers early. You say, well, that's got to be good. We must be saving a lot of lives. And yet you look at the end result and no, we're not. All this huge increase in the number of people diagnosed with cancer early, they're getting caught early, and we're not seeing an improvement in mortality for those cancers. Optimal screening frequency depends on the cancer's growth rate. If a cancer is fast-moving, fast-growing, screening is rarely effective. That's what I was talking about earlier. Even if you screen, the cancer is going to move so fast it doesn't matter. If a cancer is slow-growing but progressive with a long latency and a precancerous lesion, screening is ideal, and less frequent screening, like me with colonoscopies every 10 years, may be effective. In the case of an indolent tumor, detection is potentially harmful, but it can result in overtreatment. You know, we're talking about surgery here. Surgery for something that will never do you any harm, you won't even notice it. These observations provide an opportunity to refocus screening on reducing disease morbidity and mortality and lower the burden of cancer. Now, if we did that, what you have to say, overall, our health overall would be better. Fewer people would die, fewer people would have these infections from cancers. However, if we do that, there are going to be some people who will die who would not have died under the current system. So maybe you save 100 lives, but there's 10 people who are going to die because we changed the screening. So, you know, it's almost an impossible problem to set up because we don't know who's who. Who are the people who are going to be saved and who are not. So I like this chart. It is really dated, unfortunately. It only goes to 2010. But I think for me, if you look at prostate cancer, or even look at thyroid cancer. So thyroid cancer, so this is the number of people diagnosed per 100,000. From 1975 to 2010, we went from 5 per 100,000 to 14 per 100,000. So you think, my word, we're catching so many more thyroid cancers. That's got to be wonderful. We must be doing a great, great, great job. So what's the mortality? The mortality barely improved. Barely improved. Went from 0.55 from 100,000 to 0.51 in 100,000. How can we increase this threefold but only reduce the number of deaths by just a little bit? But you look at colon cancer, a huge improvement. Look at cervical. In fact, colon cancer, we're diagnosing fewer people with it because we're screening less often. We're more effective with our screening, but more people are being saved. That's perfect. Look at cervical cancer. We're actually finding fewer people with the cancer, and we're saving more lives. Now with breast cancer and prostate cancer, we are cutting the number of deaths, but we've increased the number of people that are being diagnosed. Now breast cancer actually looks pretty effective here. It increased 20% and down 30%, but we'll see some other data on that one. But it's an interesting way to look at it. I wish I'd seen this before my surgery. It would have been really insightful to me. The original intent of screening was to detect cancer at an early stage to improve outcomes. However, detection of cancers with better biology contributes to better outcomes. Screening always results in identifying more indolent diseases. So we're getting more and more false positives because technology is getting better. And we'll see some articles that are pretty eye-opening as far as the statistics. All right, let's talk about the PSA test. You'll see that in the video I want you to watch. So Ben Stiller, his life was saved because they caught his prostate cancer and he got the surgery. And he actually went out and promoted that. He said prostate specific antigen, the PSA test, saved his life because he had the surgery and it saved him. The actual answer is we don't know. We don't know whether his life was saved or not. So 1 out of 14 is saved, 13 out of 14 it wasn't necessary, but they could have complications from the surgery, and you'll see that. If PAC screening saves Peter, Tom, and Rajiv, but kills because of complication Dick and Anil, I don't know who came up with all these names, the net benefit is 1. If it also kills Donald, the net benefit is 0. But here is the important point. Even if the net benefit of screening is 0, it still means that screening saved Peter, Tom, and Rajiv. And if you think about it, Dick and Anil and Donald, maybe one of them were saved. One of them, if the surgery had been effective, maybe one of their lives would have been saved. But 2 of them didn't need the surgery. And so you start thinking about this as, but the way people think is Dick, Anil, and Donald, they died, but the prostate cancer would have killed them anyway if they didn't have the surgery. So the surgery it didn't go well and they died because of the surgery, but the surgery, even if they hadn't had the surgery, they would have died. But what we know is several people who don't have the surgery would have survived anyway. So it's a complicated problem. Screening is beyond net survival benefits. PSA screening can lead to harms from surgery and radiation therapy to the prostate. The value or disutility of a harm is subjective and personal. Some say he's spreading misinformation by advocating PSA screening. I'd argue that it's not possible to spread misinformation about screening because we don't have any data. Screening is an information problem. Some benefit, some are harmed. We don't know who's going to benefit and who's going to harm. But I would say it's misinformation if they don't provide that information. You're going to see in the video, it's pretty interesting, 2 doctors. One who says, we better operate, let's go in, let's cut the prostate, let's do the surgery. The other doctor says, as far as we know, it's slow progressing. If you have the surgery, there could be a lot of complications. Why don't we just monitor it? And you'll see those 2 approaches from 2 very different doctors. All right, let's talk. This is a huge one. I was not aware of this until I started seeing these articles. Cesarean sections. A recent study of 21 countries published back in 2014 or 2010, 2011 in Medical Journal estimated that 31% of births were by cesarean section. The rate is rising. The Dominican Republic and Egypt have joined Brazil in the greater than half club, over 50%. Globally, more surgery is associated with fewer maternal deaths, but only until the proportion gets to about 10 or 15%. So the ideal number of cesarean sections is 10 to 15%, and the world is at twice that. Above that level, more surgery does not mean fewer deaths in childbirth, nor are babies saved. In fact, we'll see that it actually does harm to the baby and to the mother. Women who undergo cesarean take longer to recover and are more likely to feel depressed after the birth. Children born by cesarean section may suffer too as a result of not picking up bacteria in the birth canal. So if you're asking why is asthma among children such a huge issue, that could be part of it. A study found that 2 million children born in Denmark between 1977 and 2012, the 14% had been born by cesarean section were much more likely to suffer from ailments including asthma, arthritis, bowel inflammation. So yeah, asthma is increasing dramatically in the U.S., Is it because more and more children are being born by cesarean section? Some people, I'm not a doctor, but that a natural birth actually exposes infants to certain bacteria that improves their immune system, and so cesarean section may actually be harming that. Huge differences exist between hospitals. So again, not only is this overdiagnosis, but it's also inconsistency, cost, and quality between cities. But American hospital rates can rank, look at this, from 7% to 70%. So the 7%, that's too low, right? We saw 10 to 15 was the ideal number, but 70%, that's a hospital whose doctors just don't want to have to mess with a pregnant woman sitting in our hospital for hours waiting for the baby to come. They just say, let's put it, we want your baby to come on schedule right when we want it. So pretty incredible. Hospitals, neonatal wards profit handsomely from cesareans. In the time it takes to assist a single natural birth, a medic might perform several cesareans. That's a good quote to think about the incentive of overdiagnosis. Some charge patients who insist on the time-consuming natural birth with a standby fee. Many doctors are wary of the malpractice suits. There's another, we'll talk about malpractice, so that's another issue with the problem is if doctors are worried about being sued, so they order stuff that really shouldn't be ordered. That can be part of the problem. Obstetricians are hit with even more lawsuits than plastic surgeons. So there you're seeing a few things there. I didn't even mark. You need to go back and mark this one. I forgot to mark medical malpractice on this one. So there was a good one. Cesarean sections may be driven by doctors worried about medical malpractice. So here's a chart on cesarean, and you can see, we said the ideal was 10 to 15%. So you can see the countries that are there. We'll talk about Costa Rica, my favorite country outside of the United States. And they do have a good reputation for their healthcare system. And then you see some that are way too low, right? Poor countries, they can't afford to do them. And they may have a lot of at-home natural births. But some countries are up there into that. We talk about Brazil and the Dominican Republic up in that 60% range. It's strange to me that they have Brazil as pink and oh, Mexico's pink. I'm sorry, I thought Mexico was that blue one. But anyway, you can see the range is absolutely incredible. And then they look at the maternal mortality. So obviously, once you get below that 15%, you can see why they said 15% is ideal. Once you get 15%, the death rate really starts increasing dramatically. All right, U.S. continues its losing streak in healthcare quality comparison. The U.S. spends the most of any country on its healthcare, and yet it's ranked the lowest. There's a great quote for the very beginning of your paper. I didn't put that introduction, but this chart I'm going to show you on the next page is perfect for the introductory part of your paper. The UK, which was ranked highest, blew the U.S. out of the water. So you would think, wow, the U.S. pays twice as much as everybody else. Therefore, it must be that U.S. just has the highest quality healthcare in the system in the country, in the world. But the UK actually ranks above the U.S., not just being cheaper, but also being much higher quality. So U.S. spends more than anybody, and their outcome is just not all that good. So here's the chart. This is a pretty old chart. I wish I could get a more recent one, 2011. But you can see where we rank as far as overall quality. So U.S. overall quality is 11th. We rank 11th. The UK is number 1. And yet the U.S. we spend twice as much as other countries. Now, the U.S. does rank well in a few areas, but look at the UK. In the one place they're not ranked number 1, the U.S. is number 5. So now here they say timeliness of care. I would have thought the UK would rank lower. That's where you hear Canada's complained a lot about. That Canadians have a tough time getting a doctor, get to wait in line. So that's Canada does have that issue, but U.S. has poor medical care quality controls. But this would be a great chart to put in the first part of the paper, or at least talk that the U.S. is more expensive and yet our quality measures are no better. It'd be a good way to introduce the whole concept of the paper. The older you are, the worse the hospital is for you. Many elderly patients deteriorate mentally and physically when they're in a hospital, even if they recover from the original illness. About 1/3 of patients over 70 years old and more than half of patients over 85 leave the hospital more disabled when they arrived. So here we'll talk about poor medical care, but also talking about end-of-life care. When you see the video, you're going to see a lady that I do want to talk about who's in a comatose state. I might have talked about this in earlier class. The doctors are saying she's dead. There's no life there. There's absolutely almost fractional out of a million chance that she could ever recover. It had to take some medical miracle that someone invents something. Medicare is paying for it. They asked the son, do you want us to keep her on life support? And the son says, do whatever it takes to keep my mom alive. Whatever it takes means what? We taxpayers are going to pay millions of dollars. So you'll see that story. It doesn't really make sense to put people in the hospital with certain ailments if there's really the chances of recovery are zero. The older you are, the worse the hospital is for you. A lot of the stuff we do in medicine does more harm than good, and sometimes with the care of older people, it's less is more. Hospital staff often fail to feed older patients, get them out of bed enough, control their pain. Providers frequently restrict their movements by tethering them to beds with oxygen tanks. Doctors subject them to unnecessary procedures and prescribe redundant or potentially harmful medications. Caregivers deprive them of sleep by placing them in noisy wards or checking vital signs at all hours of the night. San Francisco General is one of them. Its acute care ward, which opened in 2007, has special accommodations and a team of providers to address unique needs of older patients. They focus less on the original diagnosis and more on how to get the patients back home as quickly as possible. So there are people out there that are trying to address this problem, but then what's the incentive they have for it? Obviously, if the elderly patient stays in the hospital longer, even though it's worse for the patient, the hospital makes more money. Why would this particular hospital say, hey, we're going to try to get the patients out of here as fast as possible? Bed rest is really, really bad. It sets off an explosive chain of events that are very detrimental to people's health. So here, poor medical care, and then again, end-of-life care. We're going to see some statistics here pretty soon that are really shocking related to end-of-life care. How hospitals handle the old and very old is a pressing problem. Elderly patients are a growing clientele for hospitals, a trend that will only accelerate as baby boomers age. One bad hospital can tip them over the edge, and they may never recover. Doctors and other hospital staff focus intensely on treating injuries and acute illnesses like pneumonia, exacerbation of heart disease, that they can overlook nearly all other aspects of caring for the patients. So end-of-life care. In addition, hospitals face fewer consequences if elderly patients become more impaired. The federal government penalizes hospitals when patients fall, get preventable infections, or return to hospitals within 30 days, but hospitals aren't held accountable if patients lose their memories or the ability to walk. So they don't measure the things that are important to the hospital's billing system. I mean, they only measure the things that are important to hospitals' billing systems. They don't measure the things that are important to the patient. And we'll get into that with Michael Porter and his approach to outcome-based medicine. Improving care for older patients requires an investment that hospital administrators are not likely to make. Some argue, however, that the investment pays off, not just for older people, but for hospitals, helping control. But why do you want to control healthcare spending if the insurance company is going to pay you whatever you spend? Those events, such as bed sores or oxygen deficiency, cost Medicare about $4.4 billion annually. Physicians who review the incidents determined that 44% could have been prevented just by different types of care. Now, it would have cost more, but 44% of $4.4 billion, you could spend a little and save a lot. In addition to outright mistakes, poor or inadequate treatment in hospital leads to needless medical spending on extended hospital visits, readmissions, in-home caregivers, and nursing home care. Nursing home stays cost about $85,000 a year, and the average hospital stay for an elderly person is $12,000, according to the agency. So, yeah, this end of life is a huge part of this. We'll talk a little later. Medicare is 70 to 80% of all the spending on healthcare in the United States, even though the elderly don't make up that percentage. So most Americans are covered by their employers, but the actual spending, Medicare is the big gorilla. So if you're going to fix healthcare in the United States, and your solution is going to be Medicare for all, you have a huge problem because Medicare is not working. Medicare is spending billions and billions and billions, even trillions of dollars, that maybe half of it is actually not helping our health, may actually be harming the health of our elderly citizens. So if you're going to do a Medicare for all, that's fine. I'm fine with that solution if you want to argue it. But you got to address the fact that Medicare has some serious, serious cost overrun issues. And so poor medical care, again. Here's an article from 2014. Total health spending in America is massive, 2.7 trillion. Those are old numbers. It's much more than that now. I think Medicare itself is over $3 trillion. That 17% of GDP is probably still a pretty accurate number. And fraud is a huge issue. So fraud and waste is something I added to the list. You'll see when we go through this book. But if the government spends $1 to track down Medicare fraud, they say for every dollar they spend, they can save $8. But budgets have been cut, so they can't spend that money. So they're not actually spending it. Some criminal, I mean, this is pretty amazing. This is, if you want to know how inefficient Medicare is, look at this. Some criminals are switching from cocaine trafficking to prescription drug fraud because the risk-adjusted rewards are higher. The money is still good, the work is safer, and if they get caught, the penalties are lighter. I'm going to show you some Medicare fraud in this book we're going to see the summary of, and you will be absolutely shocked, not just at how bad the fraud is, but at how our government refuses to respond to it. And why is it? Because the government has no incentive to save future taxpayers' money. And so they're stealing patients' identities. Medical records are worth more to crooks than credit card numbers. So, you know, the healthcare system is so inefficient, so poorly run. I'm not saying Medicare employees are incompetent. We'll see later that the problem with Medicare is the volume is so high, no one has time to review these bills, and so they're just getting paid. So fraud and waste, yeah, that's a good one for fraud and waste. Perfect quote. So when you get to the fraud and waste, what better evidence can you give than that? Why our healthcare care lets prices run wild. The U.S. has the highest rate of obesity. So here we can get into the American lifestyles. So we have the highest rate of obesity, although the rest of the world is definitely catching up with us, which is usually a factor in higher healthcare costs. But the U.S. is not high on everything. So U.S. doesn't smoke as much as China and the U.S. or the Soviet. Russia. We don't have as many over 55s as Europe and China and Asia has, Japan especially. So while obesity is an issue in the United States, we're not older than the rest of the world. We don't smoke as much. And in fact, we don't drink as much as the rest of the world. So the two often cited culprits were fear of malpractice lawsuits and our complex healthcare payment structure. Doctors and hospitals practice defensive medicine. So there's something related to Medicare and malpractice. But why do we have this complex structure where we're overusing insurance? I'm going to argue it's the tax code, so we'll have to talk about the tax code here. So fee-for-service medicine, in which hospitals and doctors are paid separately for every treatment, that also gives us overuse. A central reason U.S. healthcare spending is so high is that hospitals and doctors charge more for their services, and no one really knows why. So essentially this article is saying, we don't know. It's so complex. There's no uniformity in the system. Unrelated contracts with hospitals and doctors and the public-private insurers. The result is that a tangled, confusing, and largely secretive collection of forces driving healthcare prices higher. This is why a hospital hosting 5 patients for knee replacement might get 5 different amounts charged for the surgery. So focus on treatment, complexity of the system. You could put in there inconsistency of cost and quality city to city. And I get back to what I said earlier, Medicare is the big gorilla, so Medicare could fix a lot of this if Medicare simply demanded certain procedure and uniformity of the system. All right, so we've been going quite a bit here, about an hour. Hopefully you're getting good notes. I'm going to stop at an hour so you have an extra 15 minutes of this class. if you've been pausing the video to copy and paste some of these, we'll start here on this article from 2015 and get a little bit of this evidence-based medicine and why it's time to fix that focus on treatment. So we'll start there. We got about 3 more classes or 4 more classes that talk about healthcare, and there's a lot of good articles coming, so I'm really excited to show some of this stuff. I don't know if I'll get an outside speaker, we'll see. But we'll stop it there and get some good notes. Make sure you're staying organized.